Assalamu alaikum. I'm Dr. Faiza Saeed, consultant nephrologist at the Indus Hospital and Health Networks. I welcome you all to the scientific session of nephrology department at ICON 2022. We have in today's session we have two talks and we have four panelists. The first talk is basically by Dr. Professor Asim, Dr. Professor Waqar Ahmed, sorry, and we have two panelists in this talk, the Dr. Professor Asim, who is the head of the nephrology department and dean at the Kidney Center, Karachi. And with him, we have Professor Noman Tarif as co-chair. He is the head of the Department of Nephrology at Fatma Memorial Hospital, Lahore. So the first speaker today, we have Professor Waqar Ahmed, who is the former president of Pakistan Society of Nephrology and currently the head of the nephrology department at Shaikh Zaid Hospital, Lahore. He is working extensively to develop a renal registry in Pakistan, and he will be speaking today on challenges in developing renal registry in a developing country. So,
my name is Professor Waqar Ahmed. I am head of Department of Nephrology at Sheikh Zaid Hospital, Lahore. I have worked as president of Pakistan Society of Nephrology for 2 years from 2017 to 2019, and also worked as General Secretary Pakistan Society of Nephrology from 2010 to 2017. I am thankful to the administration of the Indus Hospital for giving me a chance to talk upon the topic of data collection, hurdles, and successes so far in Pakistan. We all know patient registry have a great potential for providing data that describes the disease burden, etiology, outcome with different disease modalities, disease trends at different times of the history, and future planning for the different diseases. This is a world over. We know that these are the facts and we cannot deny these facts. The disease data has an important role for the planning, for the disease, to know about the diseases, to know about the etiology of the diseases, and different types of etiology, kidney contribution in diseases are different in different diseases. Moreover, with systemic and comprehensive analysis, we can audit the services provided for the disease, and we can plan the clinical management and outcome of the disease. Keeping in view all these benefits, all these goals, the first renal data system was launched in European with the name of European Renal Association Dialysis and Transplant Data. European Dialysis and Transplant Association Registry, sorry. And it was launched in 1964, and this is called as the oldest renal registry in the world. The other well-known data registry is the USRDS, the United States Renal Data System, and it was started in 1988 with the funding of National Institute of Diabetes and Digestive and Kidney Diseases, with support from the Center for Medicare and Medicaid Services. It was started in 1988. In our neighbor country, in India, the renal data was started to collect in 2015 with the support of the Indian Society of Nephrology. But in Pakistan, the renal registry was started by Dr. Ali Jafar Naqvi in 2005. And this was a manual type of renal registry that Professor Jafar Naqvi was sending forms to all over the Pakistan and was collecting these forms and was analyzing the data manually. The last registry was published in 2014, and 2014 to 2018, there was no registry publication. In 2018, Pakistan Society of Nephrology started PKRDS, an online renal registry system. This registry was planned to collect the data of the hemodialysis patient, glomerulonephritis, to know about the different types of glomerulonephritis, their outcome with the different treatment modalities. And third registry was planned for the renal transplant patients. How many patients are being transplanted, what are the cause of the end-stage renal disease in transplant patients, and what are the outcome of these transplant patients. But till now, we are successful to launch only the hemodialysis registry. Just to give you an awareness about the PKRDS, let me to show the website of the PKRDS and how it works. This PKRDS was launched in 2018, and as I told you initially, we have planned for the hemodialysis registry, GN registry, and transplant registry. But unfortunately, till now we are only could be able to launch the hemodialysis registry. This hemodialysis in the hemodialysis registry, first of all, we request the centers to be registered with us. In the registration, they give us the total number of dialysis machines, total number of technicians, total number of hepatitis C machines, total number of hepatitis B machines, and negative patients. Once we approve the center, we request the center to fill the patient data. The patient data is not so much complicated. We need their biodata, their labs, their cause of etiology of the renal failure, and their comorbidities. Once we receive the data, it is pooled in a central data system. The center can see only their own data. They cannot see the other centers' data. They can analyze their data, how much hepatitis B patients are there, how much hepatitis C patients are there, at what time of their dialysis the patients are converting into hepatitis B or hepatitis C, what is their mode of vascular access, what is their mode of how much patients are getting twice a week dialysis or thrice a week dialysis. But the admin can see the data of all the centers. Let me to see you how the patient can be. The admin can see the patients like that, and with these fields, he can analyze any center, can analyze the patient from any province, can analyze the patient from any district, or from some specific date up to specific date. He can analyze that what is the how much are the new patients from these days during this period, and what was the source of, what was the type of their vascular access, how many patients were getting the twice a week hemodialysis, and how many patients were getting thrice a week hemodialysis. What are the cause of end-stage renal disease, and who were from where they were getting the sponsorship of for the dialysis. Let me to repeat it that the center having the same sort of screen with them, but they can analyze their own patients. They cannot interfere, they cannot analyze, they cannot see the other centers' data. So now coming back to my PowerPoint presentation, up till now what we have done. We have done 99 registered centers, and in these 99 registered centers, almost 1900 patients, we have collected the data for the 1900 patients, and we publish this data in Pakistan Journal of Kidney Disease quarterly. While describing the data of our patient, what is our aim, what is our mission? We characterize the hemodialysis patient. Patient's की age क्या है? What are the age characteristics? What are the gender characteristic of the patient? What is the most common causes of the ESRD in our country? And standards of the dialysis treatment, how many patients are getting adequate dialysis by looking upon their lab parameters, and how many of them are getting inadequate dialysis. How many of them are getting twice a week dialysis and how many of them of getting thrice a week dialysis? How many are vaccinated and how many are not still vaccinated? And in future, after passing few years, we will be able to compare the data of the 2021 or 2020 with 2024 or 2025. What are the change in the data? Is there any change or we have the same statistics? So we will be able after a few years to track the trends of the mortality, disease course, their outcome, and their comorbidities. comorbidities. We are also doing the investigation and relationship among patient demographics so that at which area we are getting more patients, at which area the cause of ESRD is more common, and at which area in getting the adequate dialysis and which specific areas are getting not adequate dialysis. If somebody requests the data to see in depth into the data and to do some other researches, we can give the data after removing the center name and after removing the patient name in an Excel form. So he can do lot of research, even these 2000 patients having adequate number of patients, and if somebody requests, we can provide the data. Such, for example, if we can compare the hemoglobin level in a twice a week patient, twice a week hemodialysis patients and a thrice a week hemodialysis patient, we can provide the data for these further studies. What are the hurdles so far which we are facing? There is no help from the government. Till now, we have no help from the government, and it is very difficult for me and for my colleagues to go to center to convince the people to get the dialysis, to get registered with the PKRDS and to upload the data. So we have to hire a data collecting company, a professional data collecting company, and we are paying them monthly for their services. But let me to say, till now, we are arranging all these funds by our own self. We have no support from the government. And the second most common hurdle is the lack of awareness. When we go to the different centers, we try to convince the people that you should upload the patient data. The first question is what we will get out of it. We have to convince that although you will not directly get out of it something better, but in future it will be helpful for all of us. So we have to convince them, and a lot of time have to be spent to convince the people looking after the different dialysis centers. And the third most common hurdle is the ESRD etiology. I will show you the last data which we have been published in the PJKD, that most of the time the ESRD patient having the hypertension. When the data collector communicate with the patient or with the dialysis in charge, they just say that the kidney is failed because of the hypertension. Even the patient is having if something else as a cause of ESRD, such as chronic GN or bilaterally shrunken kidney, because of unknown reasons, they ultimately develop the hypertension. But the patient and the dialysis center in charge just know that the kidney is failed because of hypertension. So they just communicate that as the blood pressure is the cause of hypertension. This is one of the technical hurdle which we are facing till now. So we have to mention in the data analysis that these are the patients which developed hypertension and renal failure because of unknown origin. And finally, some of the centers raise the issue of the privacy concerns, that the patient data is very much private and they cannot share with the PKRDS. Although we have tried our best that this data is safe, nobody will can access to the data. No other center can interfere their patient's data, but still we have to work hard to convince these people. What are the solutions for these hurdles? Government funding. We are trying to reach to the government officials, dedicated regulatory body. I have raised and some of my friends also raised that there must be a dedicated regulatory body. And third point, that incentives for registration with the PKD, and with other part of the world, that the centers which are not registered with their data collecting body, they are not allowed to do the dialysis. They are not to provide the, they are not getting the government funds. Some kind of incentives should be initiative in Pakistan also. We have already hired private data collectors. I have told you, and we are paying them monthly heavy amount of money to them. We are also going to the different centers, myself, my colleagues, to convince to further data sharing and to give them the initial know about the PKRDS, as I have told you earlier. And we also ensure all of these people who having any doubt about the data privacy problems, that we have ensured up to the maximum that the data of the patient will not be leaked and anywhere else. What are the benefits to share these data? I have told you that those centers who are participating with the PKRDS can ask all the data at any time. We will give them the data after removing the patient name, after removing the center name. So they can do lot of work on this data. Lot of data is there already, and they can ask the data to do new fields of the research. Let me to show you the last publication in the PJKD. I have told you that we are publishing our data quarterly in PJKD. In the last publication, we have shown that 67% of the patient registered till now, that 1900 patients, out of these 1900 patients, 67 are vaccinated, still 33 are not vaccinated. Out of these almost 1900 patients, 61 were male and 39 were females. 62 were negative for hepatitis B and C, 32 having hepatitis C and THCV positive, and 6% hepatitis B positive. We have the data, how much of these are HCV PCR positive and how much HBV PCR positive. And after how much time of starting their dialysis, they got these hepatitis B or C. If somebody will ask the data, we can provide the data and he can go for further analysis. 64% are twice a week dialysis, 30% on thrice a week dialysis, and still 3% on once a week dialysis. When we come to the vascular access, of the vascular access, 88% are getting dialysis through AVF, 5% on the temporary catheter, 1% AV graft, and 6% via the pump cat. 40% are getting dialysis with the government help, 31% with the help of the NGO and different trusts, 9% are getting dialysis with the help from their department, and 18% are getting dialysis at their own expenses. Now we are coming to the etiology of the ESRD in these 1900 patients, as it is shown on the figure, that 24% are because of diabetes, 57%, which is comparatively a large figure, are because of unknown with hypertension. We got this data as ESRD because of hypertension, but I have explained already that we are facing this problem not from this PKRDS started from 2018, but from 2005, that the centers, the doctors and patient mention that the patient is suffering from ESRD because of hypertension. But this figure is not correct. The patient developed the ESRD with hypertension actually. So we have mentioned that the unknown cause of ESRD because of unknown reason with hypertension, and these are 57% of the patients. Chronic GN 6%, stone 3%, polycystic 1%, and miscellaneous diseases 9% of the cases. I will end here and will thank you all of you for giving me time to let you know about the PKRDS. Thank you.
So the session is open for, thank you so much, Dr. Waqar. The session is open for, thank you so much, Dr. Waqar. The session is open for discussion, and I would like to hand over this to Dr. Asim and Dr. Noman Tarif for further comments on it.
Assalamu alaikum, Dr. Asim.
Assalamu alaikum, everyone. Thank you, Waqar, for this excellent presentation. Noman is joining. There are, I think, the excellent presentation, Waqar, and excellent work. I have, for basically for everyone else to understand, I'm asking these 2 or 3 questions, which I hope you will be able to answer. One is, what is PKDRS? I mean, what does it entail? Who runs it? Who funds it? Because I know personally how it's done, but I think a lot of people may not have an idea. And what is the source of funding? That's the one part of the question. The second is, whenever we have a registry, and the registries are of many kinds, people would want to know, because when you say so many patients had so many things, this is a one-time snapshot. And that's what I think it is. I mean, you can correct me if it's wrong. Because if many registries would actually have a patient identifier, and the patients are followed up in each registry. I'm not sure whether that's the case in yours thing. So patient A from my center every month has a hemoglobin, for example. Would I enter it every month, or whether this data will go every 6 months or every 3 months, and so on and so forth. And the third part is when you say, I mean, we understand that other people cannot see other people's data, which is how it should be. The question is, what is the way to get the access to all of the data? So like the admin, for example, if my center wants to have an access to all the data, would I be able to get the access of all the data with the thing? I mean, there has to be some ways. I can understand not everybody should get every data every time. So these are the first 3 questions for the audience to digest, and then Noman can ask other things. Thank you, Waqar. Thank you for an excellent presentation. Very well done.
Thank you, Dr. Asim, for your questions.
What is the way
the first thing, can you hear me? आपकी आवाज नहीं आ रही, Dr. Asim. Can you hear me?
Ji, I can hear you very well.
Ji. Actually, the PKRDS means the Pakistan Kidney Data System. The aim of the PKRDS was to collect the data for the hemodialysis patient, for the GN, and for the transplant patients. But till now, we are able to only start the dialysis registry only. It was formed by a resolution by the Pakistan Society of Nephrology in 2018 in the executive committee meeting. Yes, in 2018 के अंदर ये the meeting was held, और उसके minutes के अंदर ये resolution was passed कि एक data system होना चाहिए पाकिस्तान के अंदर भी, and we started this PKRDS. Now I am coming to your second part of your question, who is funding this. Actually, initially it was started with the help of the Pakistan Society of Nephrology. वहाँ पे funds collect किए गए थे. The funds were collected in the Pakistan till I was the president of Pakistan Society. The infrastructure was, the infrastructure I means the website, the software. It was constructed by the help of few pharmaceutical companies. I don't want to name these pharmaceutical companies. And the running cost is also being collected from 5 or 6 pharmaceutical companies, but they are not able to interfere in the running process of this data system. They are just giving the money, and we have hired a professional data collectors, और उनको हम पे करते हैं monthly, and they go to center and collect the patient data and enter in the system. Coming to the second part of your question, it is a snapshot. No, it is not a snapshot. We have asked our data collector, and what we are doing, those जो center खुद data collect कर रहे हैं उनको भी communicate करते हैं. After every 6 months they have to update their patient data. उनके अंदर उनके suppose के patient was initially dialyzing twice a week, अब वो thrice a week पे हो गया, तो वो उसका डाटा अपडेट हो जाता है, उसकी लैब्स अपडेट होती हैं, उसका ब्लड प्रेशर इज बीइंग अपडेटेड, उसका हेपेटाइटिस स्टेटस अगर वो नेगेटिव था पॉजिटिव हो गया, और अगर उसका पीसीआर आफ्टर द ट्रीटमेंट इज कन्वर्टेड इनटू नेगेटिव पीसीआर, दीज थिंग्स आर बीइंग अपडेटेड आफ्टर ईच 6 months in the January and in the July. So this is not a single snapshot, it is a continuous process, और उसके अंदर वो every 6 months के बाद उसको डाटा को अपडेट किया जाता है. Although we are publishing the data after every quarterly, लेकिन इसका सिस्टम जो पेशेंट का डाटा वो 6 months के बाद अपडेट होता है. Even if the patient is being transferred from one center to other center, उनकी क्योंकि आइडेंटिफिकेशन इज विद हिज आईडी, तो वो सिस्टम अलर्ट कर देता है कि ये दिस पेशेंट इज ऑलरेडी बीइंग रजिस्टर्ड विद फलाने सेंटर के साथ उसका ऑलरेडी रजिस्टर, और उस सिस्टम से इसका पुराना डाटा यू हैव टू ट्रांसफर विद द परमिशन ऑफ द फर्स्ट सेंटर, तो उससे इसका डाटा आपको ट्रांसफर करना पड़ेगा. Now coming to your fourth question, the fourth question was about आखिरी क्या था आपका क्वेश्चन?
So about access to other people for the whole data.
जी, those people who are contributing in the data system, they can ask the data for any time. We will give the data in the Excel form after removing the center identification and the patient identification. पेशेंट नंबर 1, पेशेंट नंबर 2, पेशेंट नंबर 3 करके उनको सारा एक्सेल के ऊपर हम लोग ये जितने भी पेशेंट है मोर देन 2000 अभी हो चुके हैं, अब नियर अबाउट 2300, तो उनका सबका ये डाटा जो है वी कैन गिव देम आफ्टर रिमूविंग देयर सेंटर एंड पेशेंट नेम आइडेंटिफिकेशन, और उसके अंदर वो दे कैन एनालाइज के just I have given one example कि जी if they want to compare the hemoglobin का twice a week hemodialysis कितनी थी, thrice a week hemodialysis के ऊपर hemoglobin कितनी थी, या डायबिटीज के अंदर हाइपरटेंशन कितनी थी, और या डायबिटीज के अंदर नॉर्मोटेंसिव कितने थे, so they can do lot of work upon this data if anybody wants for it.
So just one more supplementary question because before Numan can ask is, so for example, taking the example of hemoglobin every 6 months. So if my patients, for example, in my center, I do hemoglobin every month, and by the hemoglobin changes because of my erythropoietin or not taking erythropoietin and so on and so forth. So I'm not sure how it could be made even better. So if you have, for example, every time somebody has it and it goes into that system, because you may find that one day his hemoglobin was X and the next time the hemoglobin was Y, and between that 6 months we could have done so many things. So agar uska koi mean hemoglobin lene ka tarika ho har monthly, I know it's a very difficult and a very challenging thing to say, but that's one of the other concerns.
One thing that patient update requires just for 2 or 3 minutes on the system. If anybody wants to enter the labs monthly, we have no objection. He or she can enter if he can spare 2 or 3 minutes, तो वो उसके अंदर जाके कर सकता है. The system have the option that the lab investigation can be shown or can be analyzed in 3 ways: the initial and the last hemoglobin, the mean hemoglobin, एंड द मिनिमम एंड द मैक्सिमम हीमोग्लोबिन। उसके अंदर ये ऑप्शन मौजूद है कि वो इनिशियल हीमोग्लोबिन शो कर दे, लास्ट इन्वेस्टिगेशन शो, मीन उनकी शो कर दे या मिनिमम और मैक्सिमम को शो कर दे। At the with the start we have, क्योंकि रिसोर्सेज लिमिटेड हैं, वी हैव मेड इट कंपलसरी कि जी आप एटलीस्ट 6 मंथ के ऊपर उसको जरूर अपडेट करें। इफ एनी सेंटर हैव द फैसिलिटी और उसके रिसोर्सेज हैं एंड दे कैन दे वांट कि जी मंथली उसका देयर वी हैव नो ऑब्जेक्शन, द सिस्टम इज रेडी, इट कैन बी डन।
Thank you. Noman, you want to jump in and say something? Noman, we can't hear you.
Dr. Noman, please check your internet connection. Maybe you have some problem with. He cannot hear us probably.
Faiza, is there a way of whoever is attending, can they ask questions? Because I don't see any questions. I just see questions from Noman and everybody else.
Sir, I have a few questions from the attendees. Dr. Noman, can you hear us? I think he cannot hear us.
Is it okay now?
Yeah.
Yes, Noman, now we can hear you.
Yes, it's nice.
Okay.
There's a lot of echo, but I could understand many things. It's a wonderful project, and you see, it has been my dream all the time. When I was in Saudi Arabia about like 12-13 years ago, they already had the registry for dialysis and transplant for almost like 6-7 years before that.
Noman and everybody else.
Okay, so
sir, I have a few questions from the attendees.
Yeah, I think Dr. Noman is online again.
Yes, Dr. Noman is talking.
Yes, can you hear me now?
Yes, we can hear you,
Yes,
Noman.
You see, there was a lot of. Is it okay now? Yes.
Yes, Noman, now we can hear you.
Okay, great. So I was in Saudi Arabia about like 13-14 years ago.
Again, Dr. Noman is silent.
So I think his internet connection is poor. So maybe, Faiza, can you let us know what the questions are? If you could send me the questions, I can ask them, or if you want to ask the question, you can ask them.
You can see them. Okay. Okay, the first question is, can we make a regional registry like Karachi registry? Other than the country registry, the regional registry. One question is for the regional registry. Can we make that? Dr. Waqar, we cannot hear you.
Waqar, you are mute.
Ji. Can you hear me now?
Yeah.
I don't think it is needed, but I have explained already that each center have access its own data, तो वो उसको एनालाइज कर सकते हैं हर सेंटर जो है। हाँ, एडमिन जो है उसको के प्रोविंस का या डिस्ट्रिक्ट का या डिवीजन लेवल के ऊपर कैन एनालाइज उसको कर सकते हैं। तो रीजनल रजिस्ट्री की फ़ायदा कोई नहीं होगा कि एडमिन उसको ये सारा कुछ कर सकते हैं। हाँ, एडमिन कैन गिव द राइट के जी एक सूबे के अंदर, एक प्रोविंस के अंदर एक बंदे को एक राइट दे दिया जाए कि वो अपने प्रोविंस का एनालाइज कर ले, रादर देन कि एक सेंट्रल बंदा उसको एनालाइज करे। हर प्रोविंस के अंदर एक बंदा नॉमिनेट किया जा सकता है कि वो उसको इसी सॉफ्टवेयर के ऊपर एनालाइज करके बता दे कि जी हाउ मच पेशेंट्स आर सफरिंग फ्रॉम ESRD इन प्रोविंस ऑफ सिंध और इन द डिवीजन ऑफ द कराची, उसके ऊपर कर सकता है। तो लेकिन एट द मोमेंट बिकॉज ऑफ रिस्ट्रिक्शन, फाइनेंशियल रिस्ट्रिक्शंस, एडमिन ही अभी तक ये चीज कर रहा है। लेकिन इन द फ्यूचर वी कैन डू इट कि जी हर प्रोविंस के अंदर एक एक प्रोविंशियल एडमिनिस्ट्रेटर कर दिया जाए.
So the next question is, would it be a bad idea to just start from Lahore only for the first step, or from maybe from Karachi?
We have
I think
already started it.
Yeah, I think you've already answered that question. I mean, it's already started. There are multiple areas and multiple provinces are already involved. The question is, how do we make it more robust, and how can we engage other centers to come in? That's the key challenge that Waqar is facing right now. Noman, are you back with us?
Yeah.
नुमा, आपका माइक ऑफ है डॉक्टर नुमान.
Dr. Noman, please
आपका
unmute
माइक
yourself.
में नहीं अभी तक ये चीज कर रहा है, लेकिन इन द फ्यूचर वी कैन डू इट कि जी हर प्रोविंस के अंदर एक एक प्रोविंशियल एडमिनिस्ट्रेटर कर दिया जाए.
अच्छा, उसमें ये कि जो ट्रांसप्लांट चूंकि आपने
So my
जाना
next
होता है पी
question
होटा के
is,
पास,
would it be a
होटा
bad
के
idea
पास
to
So what Noman was saying, and he's written it too, is that since people have to.
Dr. Noman, I'm sorry, Dr. Asim. Dr. Noman, you must have opened your screen behind somewhere.
How can
उसको
we
आपको
engage?
बंद करना पड़ेगा, हमें इको सुनाई दे रहा है पूरा.
That's the key challenge that Waqar is facing right now. Noman, are you back with us?
Yeah.
यस
Dr. Noman,
जी जी
आप अपनी स्क्रीन अगर चल रही है तो उसको बंद कर दें
आपका
प्लीज,
mic
उसका
off
वरना
है.
उसकी वजह से एको हो रहा है.
Dr. Noman,
अच्छा, कौन सी स्क्रीन?
Please
आपका
unmute
mic
yourself. He does not have a screen.
So Noman's question was that since Faiza, let me do it. So
Okay, sir. Okay.
what Noman's was saying that when people have to go for transplant and they have to go through Hota or Sindh or Punjab, could that be made compulsory that only registered centers could go through that? Is that correct, Noman? You can give me a nod if you want to. So that's one way of asking centers to register. Waqar?
Yeah, मेरा ख्याल है कि ये this is a good idea because we can involve the P Hota or the Sindh Hota and compulsory हो जाए कि जी अगर registered patient registered center के साथ हुआ है, या another way कि जी गवर्नमेंट जिन centers को aid देती है, suppose कि शेख ज़ैद सेंटर है या वहाँ पे patients को जो sponsor करती, and now the coming the health card जो आ रहा है कि हेल्थ कार्ड के साथ जो पेशेंट्स डायलिसिस करवा रहे हैं, नंबर ऑफ पेशेंट्स आर गेटिंग डायलिसिस एटलीस्ट इन लाहौर हेल्थ कार्ड, उन्हीं सेंटर के अंदर हेल्थ कार्ड का रखा जाए फॉर डायलिसिस विच आर गिविंग शेयरिंग देयर पेशेंट डाटा विद द PKRDS. तो इस टाइप की अगर कोई अरेंजमेंट हो जाए. वन थिंग इज इन प्रोग्रेस, डॉक्टर सलमान Suhail Sabar is organizing a workshop on probably on the World Kidney Day in the presidency Islamabad. I have suggested him that he may spare for 15 to 20 minutes on the data collection system and these hurdles also. And he agreed with me कि जी वहाँ पर भी हम लोग इस चीज़ के मतलब डिस्कस करेंगे and hopefully we may be able to sort out this hurdle in near future.
I think Noman का connection बहुत poor है, वो बात ही नहीं हो पाती. So, so the registry. So, what can I think PSN or other centers do to help you do that? I mean, I know a lot of centers that I know of course, are not still part of it. And how can we actually make this go forward to realize to make sure that centers are giving? I think there is issue of लोगों को अभी तक इतना clarity नहीं थी या है जिसकी वजह से there are some centers are skeptical to join. But I think that's something that we have to look for, and you if you can do it, it might be better. Waqar.
I think what the PSN can be done, I think you will agree with me that the PSN cannot force any center to collaborate with the PKRDS. They can just suggest. मेरा ये request होगी the PSN members कि whenever they get a chance, whenever they have any symposium, whenever they have any gathering of the nephrologists, they at least they have few words about the PKRDs. they can raise few words about the importance of the data sharing. उनको convince ही करना है ना. Till now, I and along with my few other friends of nephrologist friends, they are trying to convince. They are going to center and trying to convince the people कि जी आप उसके अंदर share करें. The same sort of help, the same sort of convincing help I need from each and every member of the PSN कि जब भी उनकी कोई गैदरिंग हो, जब भी कोई वो मीटिंग हो, जब भी कोई कोर्स हो, वहाँ पे एटलीस्ट जस्ट फ्यू वर्ड्स के जी अपने सेंटर्स को उसके साथ रजिस्टर कर लें और उसके अंदर डाटा अपना शेयर कर लें. इट इज़ नॉट हार्मफुल फॉर द सेंटर, इट इज़ नॉट हार्मफुल फॉर द पेशेंट, इट इज़ जस्ट ए डाटा एंड वी कैन लर्न अबाउट इट कि जी इसके अंदर फ्यूचर के अंदर हमें इसका कितनी हेल्प इसकी मिल जाएगी. As a body PSN, I don't think so. PSN उनको force नहीं कर सकती centers को. It is the only government and government agency जो centers को force कर सकती है कि जी वो अपने center को register करें.
I think the next PSN meeting is the biennial meeting in Quetta. And I think that is maybe that's the time that you should take some time out for your presentation, so that at least again it's re-emphasized to other. I mean, this kind of presentation that you do.
It is a good suggestion. I will contact with the organizers, Dr. Abdul Kareem, and we'll ask him when in the scientific session कि जी उसके अंदर कोई at least 20-30 minutes का मुझे time दे दें, so we can talk. और दूसरे वहाँ पे gathering होगी तो so we can sensitize about the people about the PKRDS.
So
Dr. Numan का जी.
डॉक्टर नुमान ने चैट में ये लिखा हुआ था कि ये प्रॉब्लम यही होती है, सिंस वी डोंट हैव एनी डाटा कलेक्शन, व्हेन पीपल आस्क व्हाट इज हैपनिंग इन पाकिस्तान, देयर इज नो वे फॉर अस टू टेल. इट्स अ स्पॉटेड डाटा होता है उसकी वजह से. दैट्स व्हाट डॉक्टर नुमान सेइंग. सो एंड ही सेज the PJKD has published the epidemiological data for studies, and that is one way of doing it. So the more the data we have, the better it will be for Pakistan.
जी अभी till now तो we have nothing to tell the people कि जहाँ पर भी मीटिंग होती है they ask for the data. Till now we have no. अभी भी ये हुआ है कि 2300 पेशेंट्स के डाटा हुआ, otherwise we don't have any good data about the patient.
One question is that who will have the authorship rights for the data publication?
PKRDS. And in the PKD for the last 1 year we are in each publication we are हम लोग इसको पब्लिश कर रहे हैं और उसका डाटा आता है 2 पेज के ऊपर. एटलीस्ट ये इन डेप्थ डाटा तो नहीं है क्योंकि उसके लिए टाइम चाहिए अगर कोई उसको एनालाइज करना चाहे. एटलीस्ट जो सुपरफिशियल डाटा है, डेमोग्राफिक डाटा जो है वो पब्लिश कर रहे हैं डॉक्टर नुमान तारिफ PJKD के हर इशू के अंदर.
And I think in each of the publication, maybe if you can, I don't know how many centers you have, total number, kitna space lega, lekin you can actually acknowledge those centers. That's a good idea. And though if somebody joins new, that can be emphasized too. Noman studies can be done based on request from the researchers with the acknowledgement for URDS. Yes. So PKRDS. He said people can use it, they have to acknowledge it. जी
बिल्कुल जी. अगर वो मैंने जिस तरह पहले कहा है डॉक्टर आसिम के, if somebody asks, provided he is also contributor in the data, if somebody asks the data, we can give the data in the Excel form. This is a huge data. मैंने कहा ना कि आप जो labs हैं उनको 3 forms के अंदर आप उसको ले सकते हैं, in the form of the mean values, initial and last values, and minimum and maximum values. So this Excel data is a huge data even for these 2300 patients के लिए भी, and the researcher can do lot of research upon it. अगर वो उसके ऊपर कोई भी पेपर लिखता है तो उसके अंदर I would request them कि उसके अंदर एटलीस्ट PKRDS का जरूर वो मेंशन कर देगा. ये एक ethical responsibility if the data has been taken from the PKRDS.
It should be mentioned. I think that's the first thing कि data कहाँ का है, किस तरह से हुआ, छोटा सा preamble भी होना चाहिए with acknowledgement.
जी मेरे अपने जो PGs हैं वो अपने जब थीसिस वगैरह भी कर रहे हैं 2-3 तो उन्होंने अपने सिनॉप्सिस के अंदर तो दे हैव मेंशन्ड कि जी पाकिस्तान के अंदर इतने पेशेंट और such a number of patients, percentage of patients are getting dialysis with the AV fistula and such are getting out of AV fistula. वो मेंशन कर रहे हैं इसका डाटा जो उसके अंदर.
Sir, there's a question from Dr. Ashar Alam that is there an effort being put into for the login of the data by the institutions itself, like कि institutions खुद अपनी data entry कर दें और
Can the Dr. Ashar can hear me?
Dr. Ashar, yes, he can.
Yeah, Dr. Ashar, basically the idea was that each center will get registered with the PKRDS, and after when the registration is approved, they will enter their data by their own self in the system. Unfortunately, the people were not getting too much interest. I, along with my few other colleagues, have to go to center, और वहाँ पे उनको convince करना पड़ता था. पिंडी चला गया, इसला फैसलाबाद, सरगोदा, गुजरावाला, मुल्तान. So I have to convince these centers कि जी आप उसके अंदर करें. It was a very tiring and time-consuming practice. And then we hired a professional data collector team. We are paying them. और अगर कोई सेंटर ये कहता है कि we are ready to contribute the data, but we don't have the time, we don't have the person who can enter the data, तो वो टीम वहाँ पे जाके मेरे बिहाफ के ऊपर अपने कंप्यूटर्स के ऊपर विद अपनी इंटरनेट के साथ वहाँ पर बैठ के उनका डाटा वो एंटर करते हैं. फर्स्ट प्रेफरेंस के डाटा पेशेंट जो सेंटर है वो अपने डाटा खुद उसके अंदर एंटर करे. इफ दे आर नॉट एबल बिकॉज ऑफ टेक्निकल रीजन के जी हमारे पास टेक्निकल नो अबाउट उसकी इंटरनेट की नहीं है, जो कि छोटे सेंटर्स में अमूमन हो जाता है. और अगर वो कहते हैं जी हमारे पास टाइम नहीं है, टाइम कंस्ट्रेंट्स हैं, तो वो टीम वहाँ पर पहुँच के उनको करती है. और अभी पिछले 6-7 माह से दैट व्हेन द टीम हैज़ बीन इन्वॉल्व विद मी, उन्होंने काफ़ी लॉट ऑफ वर्क किया और वो तकरीबन हर 3-4 माह के बाद 300-400 पेशेंट्स को एडअप कर लेते हैं इसके अंदर. तो इफ़ you can add your center by yourself and can update the data by yourself, it will be the first preference. और अगर वो नहीं आप कर सकते तो वो टीम वहाँ पर हम लोग की पहुँच के मैट्रिक्स उनके कंपनी का नाम है, वो they will reach to your hospital and after your permission will do all your work by themselves.
So, what will be the solution of less contribution of data sharing and more retrieval of the data for the research from one center?
You mean कि अगर एक सेंटर जो है वो सिर्फ एक अपडेट करता है और फिर उसके बाद साइलेंट हो जाता है, तो yes, till now we don't have any objection कि अगर इवन उसने एक दफ़ा भी कंट्रीब्यूट किया एंड they want for the data, उसके अंदर ये डाटा कोई वो तो नहीं है ना कि हम लोग कहें कि जी इसके साथ उसने कोई फाइनेंशियल वो ले लेनी है. सपोज कि एक आई नो फ्रॉम वेयर द क्वेश्चन हैज बीन रेज्ड, माइट बी फ्रॉम डॉक्टर अशर, कि इस एक सेंटर के सलमान अगर एक पेशेंट सेंटर के 10 पेशेंट हैं और एक के 100 पेशेंट हैं, तो उसने 100 पेशेंट से कोई फाइनेंशियल अर्निंग तो नहीं ले लेनी ना. उस दे विल जस्ट एनालाइज कि जी उनका यूरिया क्रिएटिनिन कितना था, उनकी डायलिसिस एफिशिएंसी कितनी थी और वो क्वालिटी ऑफ लाइफ कितनी थी. सो आई डोंट थिंक सो कि देयर विल बी एनी रिस्ट्रिक्शन के जी 100 वाले पेशेंट को 100% शेयर मिलेगा एंड 10% वाले को 10% शेयर मिलेगा. वी कांट पुट सम सच स्ट्रेन्स ऑन such a data system.
So, Waqar, one more I'll add on it. I think it would be a great idea if you actually have all of this written down somewhere. And it is on your
already
website.
Written, Dr. Asif, this guideline had been written down on the PKRDS website.
जी. अब जैसे बहुत ये वाले सवाल है कि जैसे एक आएगा तो क्या होगा, कौन डाटा रिट्रीव करेगा, इस तरह के क्वेश्चन आंसर फॉर्म में होता है ना, तो उसमें जरा सी आसानी हो जाती है किसी भी को देखने के लिए. मसलन ये सवाल है कि आप खुद एंटर करेंगे कि नहीं करेंगे. आई मीन यू आर डूइंग एन एक्स्ट्रा जॉब फॉर एंटरिंग द डेटा योरसेल्फ वहां जाके, which is a facility you're providing. So if you have all of this written down somewhere, maybe in a question answer form on your website, can I enter my own data, for example, that's one question. इस तरह बहुत सारे क्वेश्चन जो आते हैं कि मैंने फॉर एग्जांपल उसके लिए भी मेरे ख्याल में आई थिंक इट हैज टू बी आल्सो डिसाइड. मैंने फॉर एग्जांपल अगर 3 साल पहले 2018 में एक दफा डेटा दिया था और अब दे रहा हूँ, तो इट इज अनफेयर टू अदर्स हु आर डूइंग इट, आप मुझे वापस सारा डेटा दे दें. तो आई थिंक उसके लिए भी कुछ आप लोगों को सोचना पड़ेगा कि भाई उस साल का डेटा आपको दे देंगे 2018 का, लेकिन 2022 का नहीं देंगे फॉर एग्जांपल. क्योंकि अगर मैंने एक दफे एंटर करके सॉरी जी बोले वकार
जी. ठीक है, ये आपकी सजेशन इज वेल टेकन कि जी अगर एक सम सेंटर हैज कंट्रीब्यूटेड इन 2020 एंड he is asking the data of the 2022. There must be some kind of constraints उसके ऊपर होनी चाहिए. I will think about it. Your first ये जो suggestion थी कि जी इसको लिखा होना चाहिए, it is already written on the website के जी उसकी guideline की सूरत के अंदर. I will also ask my जो इंटरनेट जो मेरे IT स्पेशलिस्ट हैं कि इनको FAQ इसके FAQ की फॉर्म के अंदर भी लिख
बिल्कुल
उसके
easier
साथ
हो
इसका
जाता है.
एक अलग पेज इसका बना लेते हैं. इट इज़ अ गुड सजेशन. एंड थर्ड थिंग कि जो सेंटर रजिस्टर हुए हुए हैं उनको हम फ्रीक्वेंटली उनको ईमेल भी ऑटोमेटिकली जनरेटेड ईमेल्स भी जाती रहती हैं गाइडलाइन के लिए. उनका एक व्हाट्सएप है ग्रुप भी बना हुआ है, उसके अंदर भी हम लोग फ्रीक्वेंटली उनके साथ कम्युनिकेट करते रहते हैं. बट ओनली दो सेंटर्स के जिनके जो ऑलरेडी रजिस्टर्ड हो चुके हुए हैं, तो उनका एक अलग ग्रुप भी है व्हाट्सएप के ऊपर. उनका ईमेल का भी ग्रुप है जिनको ईमेल्स जाती रहती हैं PKRDS की तरफ से. अब ये जो आपकी सजेशन है कि FAQ की फॉर्म के अंदर एक पेज कर दिया जो दिस इज नॉट ए बिग कोई बहुत बड़ी डील नहीं है, जस्ट 10 मिनट्स जॉब फॉर ए IT पर्सन, तो वो यहाँ पे FAQ भी बना के इसका एक हम लोग लगा. यही ऑलमोस्ट जो अभी क्वेश्चन डिस्कस हुए ऑलमोस्ट आई थिंक दीज आर क्वेश्चंस एंड आंसर्स कैन बी मेंशन्ड ऑन दिस पेज.
Is
Doctor, sorry, Faiza, go ahead.
There's another question. Is PSN working on launching software or application for the register center to enter the data?
Sorry, repeat कीजिए.
Is PSN working? Pakistan Society of Nephrology. Yeah.
So what she's asking is you've already answered that question. PSN से वो स्टार्ट हुई थी, लेकिन इस वक्त PSN अनफॉर्चुनेटली का कोई मेजर कंट्रीब्यूशन एज सच नहीं है. करेक्ट वकार?
ये PSN की सिस्टर कंसर्न नहीं है. इसके फर्स्ट पेज के ऊपर ही लिखा गया हुआ है कि दिस इज द लिटिल सिस्टर ऑफ द PSN. आप उसको सिस्टर समझ लें या आप लिटिल ब्रदर समझ लें, इट इज सेम PSN.
मगर सौतेला नहीं समझना चाहिए.
स्टेला ना समझे, सका समझे.
मुबारक ने एक क्वेश्चन था कि GN की कोई रजिस्ट्री नहीं है एज येट.
इसकी एक्चुअली जो हम लोग का सॉफ्टवेयर है GN के लिए वो भी प्रोसेस वी हैव उसको तैयार कर लिया हुआ है, लॉन्च नहीं किया. लॉन्च इसलिए नहीं किया डॉक्टर मुबारक के अभी तक हम लोग इसको हीमोडायलिसिस रजिस्ट्री को भी पूरी तरह टैकल नहीं कर सके. I have to do lot of efforts to convince the people, to lot of efforts to collect the fund. तो मैं सिर्फ अभी उसी की तरफ पूरा उसको मेरा ख्याल है कि GN रजिस्ट्री I will be able to launch after 1.5 year. इसको पूरी तरह मैं कर लूँ, उसके बाद मैं इसको लॉन्च करूँगा GN and the transplant registry.
तो नोमान वाज सेइंग मे बी के इस तरह करने से लिए पहले आप रीजनल करके देख लें. नोमान का सजेशन ये था GN के लिए दैट मे बी. मगर आई थिंक इन माय ओपिनियन नोमान के एक चाहे जब सॉफ्टवेयर और वो डेवलप करें वो रीजनल इस्तेमाल करें या जनरल इस्तेमाल करें, आई डोंट थिंक इट मेक्स अ लॉट ऑफ डिफरेंस. करेक्ट मी इफ आई एम रॉन्ग डॉक्टर वकार.
जी मैं बिल्कुल एग्री कर रहा हूँ. जिस तरीके से ये डायलिसिस का है कि हर रीजन अपना अपना भी इसको इस्तेमाल कर सकते हैं, इसी तरीके से रजिस्ट्री जब लॉन्च हो जाती है तो वो रीजन, वो प्रोविंस या डिस्ट्रिक्ट या सिटी जो है वो अपना उसको कर सकता है कि लाहौर के अंदर के पेशेंट निकाल के फिल्टर आउट द लाहौर पेशेंट्स, तो वो फिल्टर आउट लाहौर के हो जाएंगे. तो वो हो सकता है, बट अगेन नीड्स टेंशन, टाइम एंड फाइनेंसेस. और फाइनेंसेस और टाइम और वो एक वो if you have the finances, you have the time, you have the persons to help you, then there is no difference कि आप उसको you launch it for a city, for a district, for a province or for whole of the city, 4 of the country. तो उस वक्त तो फिर कोई डिफरेंस नहीं पड़ता. बेसिक थिंग के रिसोर्सेज चाहिए उसके लिए.
रिसोर्सेज फॉर डेवलपमेंट है ना, फिर तो कोई फर्क नहीं पड़ता कि आप वो लाहौर में करें या
इवन वी हैव डेवलप्ड द सॉफ्टवेयर, डेवलप कर चुके हुए हैं उसका वो जो प्रोसेस है कि किस तरीके हाउ द इट विल वर्क, जिस तरीके से ये डायलिसिस उसका वो भी कर चुके हुए कि किस तरीके से उसकी सारी वो जो टेस्ट ट्रायल्स वगैरह वो भी कर चुके हुए हैं. अगेन कि जी टाइम एंड रिसोर्सेज.
राइट. ग्रेट एफर्ट वकार, ग्रेट एफर्ट.
So I would like Dr. Asim now to conclude the discussion so that we can move on to our next talk.
So thank you everyone for attending this session, and thank you Waqar, excellent presentation, great convincing power. Let's hope you can convince me to one day. लेकिन बहुत अच्छी तरह से overall का registry का, and I think what is not only and I think we have to also decide, because center registries, individual patient registries, following of patients. I mean, I think that उसको जितना आप उसको बेहतर करते जाएं, as you said, जितना आप गुड़ डालेंगे उतना मीठा होता चला जाएगा, उतना डेटा आपका अच्छा हो जाएगा. लेकिन I think the importance is to convince larger centers to actually start sharing that data, because there are two big centers that I know of that are not a part of your registry, and I think it's extremely important that these two big centers join, and I hope we can make some headways to it. And I'm so sorry that Noman unfortunately was unable to communicate with us, and I would like to thank the Indus organization who did this. I know it's extremely difficult time to try to do all the meetings on web and on internet, and it takes a lot of organization. If Waqar, you want to say something at the last, you're more welcome to say.
Thank you, Dr. Asim, for your comments and for your suggestions, and I'm also thankful Indus Hospital and the ICON organizers. They gave जो basic जो aim था कि जो भी audience हैं उनको PKRDS का idea हो जाए. I think this was a good platform कि जी उनको introduction दी जाए PKRDS का, उनको motivate किया जाए and try to convince them कि जी वो PKRDS के अंदर contribute कर सकें. Your suggestions, your questions और वेल टेकन, और उसके साथ बहुत सारी चीज़ें लोगों को आई थिंक सो उनके साथ क्लियर हो गई होंगी. थैंक यू अगेन डॉक्टर आसिम एंड द ऑर्गेनाइजर्स ऑफ द आइकॉन कॉन्फ्रेंस. थैंक यू अगेन.
Thank you, Dr. Waqar, Dr. Asim, and Dr. Noman Tari for being here with us. So let's move on to our second talk of today. That's by Dr. Professor Mubarak, who is currently the head of the Department of Histopathology at Sindh Institute of Urology and Transplantation, Karachi. He has extensive work in research with 250 papers under his name, and he's a member of many professional organizations. The topic of his talk today is conundrum of infections related to glomerulonephritis and C3 glomerulonephritis. Dr. Mubarak.
First of all, I must thank the organizing committee and chair of the session for inviting me to give this talk. The topic of my talk is conundrum of infection-related GN and C3 glomerulonephritis, similar yet dissimilar. In fact, the topic was given to me by Professor Salman Imtiaz. The topic is quite interesting but challenging as well. It is challenging in the sense that I have to discuss both diseases in detail to better understand the similarities and differences between the conditions. At the same time, I will not be able to do justice with each of the disease individually. So I will focus on the main pathologic and diagnostic features of conditions rather than detail each disease discuss each disease in more detail. I have no disclosures. So this is the agenda of my talk. First, we will start with two real-life cases. Of course, they will be from pathologist perspective. Then we will revisit the terminology of glomerular disease, what is meant by glomerulonephritis and glomerulopathy. We will then discuss the causes of GN and how GN was classified traditionally and how the classification has changed in recent years. Then we will briefly discuss post-infectious GN and C3 individually. And finally, we will discuss similarities and dissimilarities between these two conditions. And we will conclude by some take-home messages. So case 1, 50-year male, he presented with AKI secondary to febrile illness of 1 week duration. However, on deep inquiry, it was revealed that body swelling was present since 3 months. Serum creatinine was 6 mg per dl, urinary protein was 3+, C3 was low, C4 was normal. And renal biopsy on morphology on light microscopy showed MPGN pattern of injury. Immunofluorescence showed diffuse positivity of C3, 3+, and weak positivity of IgG, 1+, and rest of the panel was negative. So the diagnosis was C3 dominant GN, and our differential was PIGN and C3 glomerulonephritis. EM was still awaited. Case number 2, young adult male, 19 years of age. He again presented with AKI secondary to febrilness. Here the history of 1 month, the duration was 1 month. However, since 15 days, he also developed uremic symptoms. Serum creatinine was 8 milligram per deciliter and he required dialysis. Urinary protein was 3 plus, complement C3 was low, C4 was normal. Renal biopsy in this case revealed diffuse proliferative and exudative GN. And immunofluorescence showed diffuse positivity of C3 of 2 plus magnitude. IgG was equivocal and the rest of the panel was negative. Again, our diagnosis was C3 dominant GN and differential was post-infectious GN versus C3 GN. EM still awaited. So from a review of these two cases, 2 questions arise. Number 1, is differentiation between PIGN and C3GN important? And question number 2 is it really possible? So the answer to first question is yes, because clinical course, treatment, and prognosis of the 2 conditions are vastly different. PIGN has very good prognosis, whereas C3GN has poor prognosis. And regarding question number 2, yes, in theory it is possible because one is post-infectious GN is mediated by immune complex mechanisms, whereas C3GN is caused by defects in alternative pathway of complement activation. But in practice, there are diagnostic challenges and dilemmas. Some of the caveats include that both can be triggered by infection and there's a lot of overlap in clinico-pathologic features of the 2 conditions. So regarding nomenclature of glomerular disease, it is somewhat confusing. Some names in common clinical use, for example, post-infectious GN and infection-related GN are clinical, whereas majority of the names are pathologic descriptors. The classification nomenclature was not standardized in recent past, and 2 terms are commonly used, and they will be used in this talk again and again. One is glomerulopathy, the other is glomerulonephritis. Glomerulopathy is an all-inclusive term, which includes all disease of glomeruli, be those proliferative or non-proliferative. For example, this gloom is showing minor changes, but it will qualify for glomerulopathy. But it will not qualify for GN, glomerulonephritis. Another lesion which will qualify for glomerulopathic designation is focal segmental glomerulosclerosis. There's no GN in this case. In contrast, this gloom is showing glomerulonephritis. There's proliferation, global proliferation. So proliferative lesions of glomeruli are designated as GN. Another example of glomerulonephritis, mesangial proliferative GN. Yet another example of glomerulonephritis, diffuse proliferative and exudative GN. Most severe form of glomerular injury, crescentic GN. This is also labeled as glomerulonephritis. So how to there are various, these are in fact patterns of glomerular injury to various forms of injurious agents. So how to classify them? Now traditionally glomerular disease were named as well as classified on the basis of pathologic features or their morphologic appearances on the light microscopy. In fact, 2 parameters were used. Number 1, distribution of the lesions, and number 2, nature of the lesions. For example, proliferative, necrotizing, or sclerosing. We will illustrate these names with these 2 examples. This is a classic lesion of focal segmental glomerulosclerosis. As you can see, only one of the 3 glomeruli is involved. That is why it is focal. And because only half of the affected glomerulus is abnormal, so it is segmental. So, and the nature of the lesion is that it is sclerosing lesion. So the name FAGS beautifully describes the morphologic appearance of this lesion. This is another lesion. This qualifies for segmental necrotizing GN because it is only 1 glomerulus, so we cannot classify into focal versus diffuse, but we can say there's segmental involvement, and here the nature of the lesion is different. It is necrotizing inflammation rather than sclerosing lesion as in previous slide. Another descriptive name of the lesion, diffuse proliferative and exudative GN. Exudation refers to infiltration of leukocytes within the capillary lumina, causing obliteration of capillary lumina. So this pathology classification, in fact, was showing patterns of injury. These are not disease entities. And although it was to some extent helpful, but it was not really that helpful for clinical purposes, especially in the current era of targeted therapies. So what is the best way to classify glomerular disease? Ideal classification of any disease, including glomerular disease, one that is based on etiology. If we know the cause, if we remove that cause, that cured. But unfortunately, as in many other diseases, the etiology is not known in many of the glomerular disease. So what is the next best deal? So pathogenesis-based classification is now preferred over the pathologic classification. However, before delving deeper into this pathogenesis-based classification, let us briefly review the pathogenic mechanisms of glomerular injury. A number of different mechanisms are involved in the development of glomerulonephritis. Among these, immune mechanisms are very important. Both innate and adaptive immune mechanisms are involved in causing glomerulonephritis. Among the innate immune components important ones include complement as well as inflammatory cells. Among the adaptive immune mechanisms, antibodies and T cells are important. Antibodies are much more important than T cells. And antibodies can either act alone or they may form immune complexes and then cause glomerular injury. So briefly, a few words about complement. As you can see, it is an important component of the innate immune system, but it also plays an important role in adaptive immunity as well. So it is activated by three different pathways. The two on the left, they are usually triggered by immune complexes, whereas one on the right, that is alternative pathway, this is constitutionally active. It is active all the time, which is known as physiologic takeover. But and it has got very tight. There are many factors which regulate its activity. Its overactivity leads to C3GN, C3 glomerulopathy. So classical pathway is typically triggered by antigen antibody interaction. So in that case, we investigate for infections, cancers, autoimmune disease, or any allergic reactions which may trigger this pathway. In the case of alternative pathway, we have to investigate the regulators of alternative pathway of complement activation. The final common product is the membrane attack complex that is found by both paths. These are the immunofluorescence analogs of the two different major pathways of complement activation. The one on the right, in classical pathway of complement activation, we find not only C3 complement component, but also immunoglobulins and early components of the complement system. Whereas in alternative pathway, we will find only C3 and no immunoglobulins will be found. So regarding immune complexes, among the adaptive immune components, immune complexes are very important in GN development and its causation. So immune complexes may form within the glomeruli or they may form in the circulation and then deposit in the glomeruli. In case of deposition, the favored site in the glomeruli is that of mesenterium and subendothelial space, as in shown in this figure. Because only a thin layer of endothelium intervenes between the bloodstream and these compartments. However, for inside immune complex formation, the immune complexes may form in all locations, including subepithelial location. So this schematic diagram shows classic locations of immune complexes. As we discussed in previous slide, in case of deposition of immune complexes, the favored site include mesenterium and the subendothelial space. Whereas inside immune complex formation can occur in the mesenterium, subendothelial space, as well as subepithelial spaces. Another important site, which is not shown in this figure, is that of GBM itself, intramembranous deposits, which are found in one form of C3 glomerulopathy, as we will discuss later on. Now, coming towards standardization of GN classification. In fact, a meeting was held in February 2015. A large number of world-renowned pathologists and nephrologists met together to develop standardized classification of GN and its reporting. Basically, it was consensus-based classification, and this was the product of that meeting, a paper that was published in JSN in 2016. The focal point of the meeting was to recommend an etiology pathogenesis based classification of GN and standardized pathology reporting of GN. So it basically defined 5 different types of these are in fact pathogenic types of glomerulonephritis. Please note that glomerulopathy was not included in this classification. This is classification of glomerulonephritis. So 5 different types were identified. We will focus our in this talk, we will focus our attention to the first one and the last one. The first one is immune complex GN, and the last one is C3 glomerulopathy. As you can see, patterns of injury are similar in both conditions. So pathology, in fact, morphology will not distinguish between these 2 types. One is mediated by immune complexes, whereas the other C3 glomerulopathy is caused by complement activation only. Now, few words about immune complex GN. It is characterized by, because it typifies post-infectious GN. So it is important to discuss it briefly. It is characterized by granular deposits of polyclonal immunoglobulins on immunofluorescence. Complement is often co-deposited along with immunoglobulins. Most often it is C3. The type and location of immune deposits often point to the underlying etiology. For example, if it is IgA positive as well as C3 positive, the diagnosis will be IgA nephropathy. If it is full house positive, then the diagnosis will be lupus nephritis. And infections are an important cause of immune complex GN in both developing and developed countries. This is an example of full house positivity of immunofluorescence. All 3 immunoglobulins, IgG, IgA, IgM are positive, as well as C1q and C3. Kappa and lambda are used to demonstrate clonality of immunoglobulins. In this case, both are positive, so it is polyclonal immunoglobulins. So this will be seen in case of lupus nephritis. In typical post-infectious GN, you see IgG in both the mesangium as well as in capillary walls. Here you can see it is in capillary walls, along with C3. In fact, IgG appears slightly dominant in this case, but in acute phases of post-infectious GN, this immunofluorescence pattern is found. In late post-infectious cases, you may find C3 only, as we will discuss later. This is ultrastructural electron microscopic finding in case of post-infectious GN. There are numerous subepithelial humps of variable size. These are characteristic of post-infectious GN. A few intramembranous and small intramembranous and mesangial deposits may also be seen, but these subepithelial humps are characteristic of post-infectious. Regarding patterns of injury in post-infectious GN, the patterns of glomerular injury are variable depending in part on etiology. There may be no lesion by light microscopy. Almost similar patterns will be seen in case of C3 glomerulopathy, as we will see later on. More commonly, however, there's some sort of proliferative response. This could be mesangial proliferative. Most commonly, it is endocapillary proliferative and exudative. There may be membranoproliferative, necrotizing, crescentic, sclerosing, or a combination of these patterns. And some forms of GN, for example, lupus nephritis, may have mixed membranous as well as proliferative patterns. Now, coming to C3 glomerulopathy, it is an umbrella term. It encompasses 2 different types. One is dense deposit disease and the other is C3 glomerulonephritis. Note, C3 glomerulopathy is all-inclusive term or umbrella term, whereas C3 glomerulonephritis is a type of C3 glomerulopathy. Now, coming to the definition of C3 glomerulopathy, it is basically a biopsy diagnosis. To be more specific, it is an immunofluorescence-based diagnosis, and its definition is that it is characterized by sole or dominant C3 staining with minimal or no immunoglobulin deposits on immunofluorescence or immunohistochemistry. Dominant is defined as C3 intensity orders of magnitude more than any other immunoreactant on a scale of 0 to 3. Antibody, which we commonly use, is against C3C component of complement fragment T3. However, in C3 glomerulopathy, 6 different types of fragments of C3 are deposited within the glomeruli, among which the dominant one is C3DG. This is an example of sole positivity of C3. This is very easy, no problem in the diagnosis. However, in case of dominance, this is also clearly dominant. IgG is only showing trace positivity, and C3 is clearly dominant. However, in this case, there's um, 2 orders of magnitude greater positivity of C3 as compared with IgG, which is showing almost 1 plus positivity, whereas C3 is showing 3 plus positivity. So here a little bit of subjectivity element also important. So pathogenetically, C3 glomerulopathy is associated with abnormalities in regulation of the alternative pathway of complement, resulting in overactivity or hyperactivity of this pathway. And regarding pattern of injury, as I told before, it is variable. Most often, in 70% of cases, it is membranoproliferative, but there may be mesangial proliferative, rarely there may be crescentic pattern and variable degree of sclerosing lesions. EM is used to classify it into further types, that is C3GN and dense deposit disease. This slide shows the morphologic as well as ultrastructural features of both types of C3G. And this is an example, silver stain, an example of dense deposit disease. As you can see, there's ribbon-like thickening of GBM, and it is silver negative. Silver positive thing will be black. Mesangium is black, but this GBM is here not taking the silver stain, so it is silver negative, and there's only segmental mesangiocapillary pattern. There's not much mesangiocapillary proliferation in case of dense deposit disease. In case of C3 glomerulonephritis, there's a diffuse membranoproliferative pattern with trauma tracking. You can see trauma tracking over here, here, and here. And EM, dense deposit disease, is characterized by very electron dense or very highly osmophilic deposits along the length of GBM. These are continuous over vast expanses of GBM, and they are actually located within the lamina densa of the GBM. Whereas in case of it is easy to diagnose dense deposit disease on electron microscope. Whereas in case of C3 glomerulonephritis, another type of C3 glomerulopathy, the deposits are less electron dense, less osmophilic, and they are found in all locations, including mesangium, within the membrane, subepithelial location, and as well as subendothelial location. So they are found in all locations, but they are less dense, they are discrete, discontinuous, and less osmophilic or less electron dense, and less well defined. So what further workup should be done when you get a diagnosis of dominant C3 or C3 dominant GN, as in both of our cases? So some investigations can be done on biopsy. For example, C4D staining may be used to ascertain whether classical pathway has been activated or not. C4D will be positive in case of classical pathway of complement activation, whereas in case of C3 glomerulopathy, it will be negative. Clonal studies may be done to determine masked deposits, especially of monoclonal immunoglobulin deposits on IF testing. Proteomic profiling by laser dissection mass spectrometry, it is still in experimental phase, not used clinically, but may be done to determine the nature of the complement fragments deposited within the glomeruli. And pathologists can also use C3 histopathological index, which includes both activity and chronicity scores, to determine the prognosis of the individual cases. Again, if you get a dominant glomerular C3 deposition, there are 2 possibilities: C3 glomerulopathy as well as post-infectious GN or other immune complex mediated GNs. C3 glomerulonephritis is divided into dense deposit disease and C3 glomerulonephritis on the basis of electron microscopy. And the other tests that may be used in further investigation of C3 dominant GN include complement factor assays, both functional as well as quantitative analysis. Functional assays can also be used. Genetic tests of various complement factors as well as the regulatory factors. For example, and autoantibodies are also important. Examples include C3 nephritic factor, anti-complement factor H, anti-factor I. These antibodies can also be tested. Monoclonal immunoglobulins may be, or paraproteins may be investigated. However, these all tests are not widely available, and their turnaround time is also very long, more than 1 month. And there's also some overlap in findings. And there's interpretation of some of these results is also more complex. In case of genetic tests, autoantibody testing, the genetic abnormalities or autoantibody may be found, may not only be found in C3 glomerulopathy, but also in cases of immune complex mediated GN. So their interpretation requires expertise. So what are coming to the main, our main topic, what are similarities between post-infectious GN and C3 glomerulopathy? Of course, age both affect children, adolescents, or young adults. Clinical presentation may be same. Laboratory features are also more or less same. Morphology is also same, although there are some differences. In case of C3G, membranous proliferative is more common, whereas in case of post-infectious GN, more commonly it is diffuse proliferative and exudative GN. And what are dissimilarities? So now, duration of disease is short in case of PIGN, whereas it is prolonged, typically prolonged in case of C3G. Immunofluorescence findings are, of course, separate the two, but there may be overlap. So we have to be very careful. Sometimes clinical course of the disease is the only final arbiter. So this table shows important differences between the three common differential diagnoses. As you can see, post-infectious GN has got numerous subepitheliomes. So are also found in the atypical post-infectious GNs, numerous subepitheliomes. Whereas in C3 glomerulonephritis, there are mostly mesangial and subendothelial deposits. However, subepithelial humps may be seen. So there's overlap among all the features. Finally, to conclude, C3 glomerulopathy is a relatively newly defined pathogenic type of GN. It is still in evolving phase. It is a heterogeneous group of disease, not a single entity. It is a heterogeneous group of disease with two subtypes and many transitional forms. Currently, the definition relies completely on immunofluorescence testing. In future, we may have more biomarkers for non-invasive diagnosis of the condition. Morphological patterns are variable and non-specific. It has overlapping features with post-infectious GN and MPGN. However, its accurate diagnosis is essential for optimal treatment and prognostication. Thank you very much.
Thank you so much, Dr. Mubarak.